I'll do it from here.
What's happening again? I don't think it's a problem on my side. But it's okay. I think I won't be seen much. Dr. Pankaj will be on the screen anyway.
Yeah. It's happening for the first time. We have another 2-3 more minutes.
No, it's 7:30 now.
7:30, yeah. Should we wait for 5 minutes? 2 minutes we'll wait for people to enter, then we'll start.
People are joining, you can see that, yes.
Yeah. Hello, everyone. Good morning, good afternoon, good evening, depending on whichever part of the world you are in. Hearty welcome to today's session of Learn from the Legends, jointly organized with National Neonatology Forum India Neonatal Expert Talks. I would now request my co-host, Dr. Abhay Matthew, to introduce the moderators and the faculty for the day. Over to you.
Thank you, Dr. Manoj. Hearty greetings to all. At the onset, I would like to welcome and introduce the two moderators of the session, Dr. Archana Bilagi and Dr. Abhirama Leda. Dr. Archana Bilagi is working as a consultant neonatologist in St. Philomena's Hospital in Bangalore. She was Secretary NNF Karnataka in 2014 to 16. She is an active NRP instructor and in NNF accreditation of NICUs. And she is the author of a chapter in textbook of clinical neonatology and a section editor in textbook protocols in perinatology. Welcome you, madam. Next, I would like to welcome Dr. Abhirama Leda. She is Associate Professor and Consultant, KMCH and KMCH Institute of Health Sciences and Neonatology Research, Coimbatore. And she has many awards and positions. She is Associate Editor, Cochrane Neonatal Young Researcher Award from IAP. And she has about 54 publications, including 5 Cochrane meta-analysis. And she has authored chapters in many neonatology textbooks. And she is a peer reviewer in several international journals. And her area of interest is neonatal research and neonatal neurology. Welcome you, madam. I have a great pleasure in introducing our renowned speaker of the day, Professor Pankaj Agarwal. And Dr. Pankaj is Chief Division of Neonatology, University of Miami, Jackson Health, Chair, Project, Newborn, Professor of Pediatrics and Genetics, University of Miami, Miller School of Medicine. He is also currently visiting scientist, Boston's Children's Hospital. He is a visiting Professor of Pediatrics, Harvard Medical School, Boston, Associate Member of the Board Institute of MIT and Harvard. He has published more than 150 papers in several high-impact journals, including NEJM, Nature Communication, JCI, Genetics in Medicine, Human Molecular Genetics, JACC, Molecular Psychiatry, Blood, European Respiratory Journal, Developmental Cell, Brain, Annals of Neurology, JAMA, etc. And he's a principal investigator for the Virtual Genomics Center in Infant Health Project funded by NIH. And he's also investigator for the Undiagnosed Disease Network at the Harvard Medical School. And he funded by various foundations and NIH grants, including R01, U19, and UM1 grants for his research. And he also has received several awards for his clinical and research work. Over to you, Professor Pankaj.
Thank you so much, Dr. Matthew, for such a kind introduction. And I also want to thank Manoj, Dr. Manoj and his team and NNF for really inviting me and giving me this wonderful opportunity to talk with everyone about the work I'm doing in the genomics area. And you will see how we are trying to make a difference in the care of newborns. So I'm gonna start sharing my screen. Hope you can see it. Is this good to go?
Yes, we can see the screen nicely.
Oh, perfect. So as Dr. Matthew said, I have recently moved to Miami from Boston. I was running the Genomics Center at Boston, and recently I got opportunity to become the chief. Dr. Bankalari, if you know him or you may have heard his name, he was retiring, so I've taken his position. So it's a great honor for me to be now in Miami. But I'm going to just start with saying that my research into genomics started with taking care of this gentleman who was a newborn when I was doing fellowship. And if you see, he is on a ventilator. He's a tracheostomy, and he is on a like he's immobile. And when he was a newborn, we took like months and months to really get to the bottom of what his condition is, because he was born with, it was called HIE, or hypoxic ischemic insult, encephalopathy. It was, those days we were not cooling the kids, but he would have been cooled if he was born today. But he just did not move a single muscle. And it took us like, go through the diagnostic odyssey of all the different testing, spending millions of dollars and spending 6 months to really get to the diagnosis. And the diagnosis was a condition called myotubular myopathy. So that sort of piqued my interest in genomics and myopathies. And that's where I started my career in the lab of Dr. Alan Beggs, who's here on the right. And these are the parents, and this is one of the genetic counselors. So that's how my career started in 2002. And since then, I've continued to focus on genomics and its various applications in rare disease and newborn care. And that's what I'm going to focus on, newborn care today. But just to say where I started from, and sometimes a single patient can change your life and put you into. So always remember to see what you can learn from your patients and see if that can be a potential research area as well. So if you see, I'm going to talk about these different parts of neonatal care. The first one, which is very close to our heart, is the NICU, how genomics can help babies in the NICU with these advancements in rapid genome and exome sequencing, how we are using this approach also in babies who die of unexplained cause, and then implementing how helping babies in the resource poor NICUs. That's what have been my goal in the last few years, and I will talk about it a little bit. And then more and more, I'm sure you have heard of like how it can make a difference in healthy newborns as well as part of screening. And there is a lot of controversy about this, whether the babies can benefit from a healthy baby who is born completely fine, and whether we should do sequencing as a way of screening them. And I'm going to touch base on that as well. And then I'm going to talk also about some of the research opportunities in this area, how we are also building therapeutics as one of the goals in these precision medicine and or N of 1 cases where we can try to find treatments. And then I built in the country a program which we called as Neonatal Genomics Program, and what we are doing under that program while I was at Boston. So these are some of the topics that I'm going to touch base. So as we know, many of these babies who are admitted to the NICU do not have 10 to 20% of them have some type of genetic disorders. And then these infants undergo a long, expensive diagnostic odyssey, which takes months and months, and often it's not still diagnosed. So that is a problem we face sometime in the NICU. I'm sure you have faced that in your own NICU. And then which test to order, that's another challenge. And can there be one single test that we can send and not worry about what type of test to think of or send, or ask a genetics friend, or can we just send one test and be done with that? So in terms of rapid sequencing, I'm sure I talked about that patient that I took care of in 2001, 2002, who was born floppy, and then we did pretty much all these workup that I have listed here on that child, and think of all these tests being replaced by a single test, which is genome or exome sequencing, and we can get to the diagnosis, versus all these tests and still not able to find out what's wrong with the child. So this is a much more cost-effective and much quicker in terms of diagnosis. So the first approach of this rapid sequencing, in fact, the first time exome sequencing was utilized and was in 3 families who had Miller syndrome, and they found the gene responsible using exome sequencing. But in 2012, a landmark paper showed that rapid sequencing can be done in 50-hour turnaround time, and they were able to diagnose 4 out of 5 cases. And since then, these type of studies have been done all around the world, in US, Europe, and Australia, and I hope someday we will be able to also do something similar in India, or maybe it's already being done. And then we did also our own research study to see how useful this approach is. So we did this case control study during 2017-18, where we use historical controls as our control. And then we enrolled the NICU babies within a week of admission, and this was performed at Boston Children's. And we analyzed trio exome within 5 days of enrollment. And so we wanted to look at what's the diagnostic yield, how much time it takes to diagnose, what's the impact on care, and number of tests ordered, and costs associated. So we came up with a certain criteria as a unique part of our study, where we said, let's look at these type of patients where we think it has the most utility. So we said, let's go for hypertonic kids, like the first one that I talked about, or those with unexplained seizures who have multiple anomalies, and then these other 4 conditions that I've listed here. So we looked at the majority of our patients were in the top 3 categories, and then there were occasional cases in this. So we had approached 57 probands and enrolled 52 of them and sequenced 50 of them. And then in about 58 or 60%, we had a definitive or likely diagnosis. In fact, early in the study, we had a pretty high rates, but that dropped as we opened it to more sites. And at the end of the day, we had a diagnostic rate of 58%, which is fairly high based compared to other studies. But I think because of our selection of the 5 phenotypic criteria, it increased our diagnostic rate. I'm sure we also may have missed a few cases, but overall it was a pretty interesting experience. We also got the data from 21 cases who are undiagnosed for reanalysis, so that we can use our own reanalysis pipeline to look at those and find what's going on and if we can diagnose them or some of them. So how did it make a difference? It did make a difference in so many ways. For a couple of patients, we were able to tailor their therapies. For example, there was one child who had a mutation in a gene called SCN2A, and that child was, based on the mutation, is more responsive to phenytoin, and that's what was done, and the child had a better control of seizures. And then there was one patient who had a mutation in a gene called MTM1 or myotubularin, and that child was eligible for a gene therapy trial, but the family decided to not pursue further care, and child was redirected to palliation. And then, in addition, there were other implications for these patients. For example, some of them needed additional specialists to be involved because we never suspected they would have this condition, but based on genetic finding, we said that this child will need referral, for example, with endocrine or some other specialist. It helps. A lot of them were benefiting from the impact on their family planning. And I'll show an example of that in a little bit later. We were also able to make quick decisions for families once we have the diagnosis, so that they can either decide to redirect care to early comfort care, or they can go for tracheostomy or gastrostomy, and they can be going out of the hospital sooner rather than later. So there are multi ways of benefits, maybe not be as direct therapies, but there are many additional benefits to the patient and the families. So we did this study in 2017, 2018, and then we wanted to see how this has changed care in the NICU. So we did not have this approach of rapid exome or genome sequencing in the NICU before the study, but after the study, based on the results, the hospital and the administration, they have found value of this approach, and we have integrated rapid exome sequencing into our routine clinical care. But now, instead of that definitive diagnostic criteria that I showed, those criteria that I showed, phenotypic criteria for enrollment, now it's in the hands of the genetics team, and also input from the NICU and other. There's a hospital oversight committee who decides whether the patient will benefit from exome, but it's mostly started by genetics. And then there is always clinical team members are rotating. So some people strongly feel that we should get a genetic testing, some don't. And sometimes there is a competing clinical demand. So what was our experience in those kids? And after this study, we found that, in fact, we are doing a lot of exomes. So out of 230 patients who had a genetic consult, 80 of them got rapid exome and 150 did not. But out of those 80 who got exome sequencing, majority had a neurologic phenotype, which is hypertonia seizures. That's what we started with, which we proposed. So you can see most of them did get, out of 39, 31 of them got rapid exome, or those who were critically sick, unexplained, and they also got a lot more exome. Or those who died also got, they had a higher chance of getting exome compared to other conditions. So it's interesting that critically sick infants are more likely to get exome, which makes sense, but that's what we found. And then our diagnostic rates was 28%. So the first time we had a diagnostic rate of 58%, and this time it was 28%. I think it's just, I don't think, we don't need to read too much into it, but the range of diagnosis is about 28 to 55 to 60%. And that's what a lot of studies have found. So sort of matches with what we found in this follow-up study. And one of them where rapid exome filled missed a diagnosis needed additional testing. So there will be cases where we will miss them, but a majority of times we will find the cause, and that's important. So I want to move to molecular autopsy as an example of the utility of this approach. So this is a patient. I want to talk about this. This is a full-term baby who was born at 41 weeks gestation. And first, everything was fine, normal lab curves. But the first day, the child was noted to be a little pale and hypertonic and was also not feeding well. So they sent the baby to the NICU. And they did the full workup, including rule out sepsis, had cultures taken, had a head ultrasound, which was fine, had X-ray, they even got an echo. They also got eyes examined, and the child had failed hearing screen. So that was a little unusual. But they then, based on this, they decided to get MRI. And it showed some abnormality to prolongation and some small lactate peak, which made them consult genetics and metabolic teams. And they did all the initial workup, including plasma, urine, and CSF testing for all the metabolic tests. And nothing came back positive. And then they also sent a microarray, which was negative. Child had some periodic breathing, and then which improved on caffeine and has passed CAR-C test. So was sent home on day of life 18 on caffeine and an oxygen saturation monitor. So pretty nonchalant, everything looks, there were some signs that something is going on, but at the end of the day, they felt comfortable because they did all the basic testing and all came back negative, felt comfortable sending the child home on a monitor. Anyway, so the child stayed at home for 3 days. And then after 3 days, was noted to have several episodes of apnea at home. And that's when the family brought the baby to our NICU. So this is a different NICU. This is a birth NICU, and then this is the Boston Children's Hospital NICU where the patient came. And it was noted to have multifocal seizures, was treated with phenobarb. But this time the MRI was grossly abnormal. There was areas of reduced diffusivity. The lactate peak was worse. Again, more testing. Again, they also did a whole global metabolomic pathway, which was all non-diagnostic. So that time we were doing the study that I talked about earlier. And so we enrolled them in our research study. We sent the blood samples for DNA extraction and skin biopsy, and also to culture fibroblasts, so that if we need to do some additional testing, we can do it. And then on day of life 27, the infant died. And the family decided to go for autopsy, which was also not very useful because they found some atrophy, some steatosis in the liver, and some LVH, but nothing out of the ordinary and no diagnosis yet. So because this child was part of our rapid exome sequencing study, we found child has to have 2 variants in a gene called HIBCH. Now, this is a mitochondrial enzyme that is involved in valine catabolism, and this deficiency is associated with Leigh syndrome. But why they were missing the metabolic workup, it seems like the child, usually there is a C4OH elevation with this condition, but this child did not, and that's why they were, this was not even considered as a differential. And the disease was also much more severe than what is reported in the literature. So at the end of the day, the clinicians were still not convinced, especially the metabolic team, that because one of the variant was a VUS and one was pathogenic, they said, we still don't know, or we don't believe that this is the right cause. So luckily for us, because we had fibroblasts, and there was a lab in Europe that was doing testing for HIBCH activity, and they tested the patient cells and they found them to be severely deficient. And that clinched the diagnosis for the family and for the clinicians. And the family has used this information for pre-implantation genetic diagnosis and now have 2 healthy boys. So they were super thankful and excited and happy that they found the cause and also used this information because there was a 25% chance of recurrence, and started to do fundraising for my lab. And they raised $72,000 in 2018, and then did another fundraiser in 2021, and did another one this year, and they have raised more than 200,000. So this is an example of how one case can really, we can learn so much, and also sometimes it helps to get your funding for the research that we're trying to do. So just as a genetic cause of infant mortality, we had done a study where we showed that 573 infants died between 2011 and 17, and 288 of them, so almost half of them, had some type of genetic workup as a prenatal molecular diagnosis or postnatal genetic evaluation. And 124 of them had a molecular or cytogenetic disorder. So this is before the time when exome was routinely done in our unit. So you can see that I'm sure we are missing a lot of these, and we could have higher diagnosis if we were using exome on a regular basis. So moving on to the next topic, area of my research interest is how we can, so this technology, at least in the US, is available in only major level 4 NICUs, and that also on a case-by-case basis. And we have to jump through the hoops to get the approval from departments and hospital, because it's an expensive test, although the expenses are coming down every day. So we wanted to see if we can use this as a telemedicine approach, where we can reach out to NICUs around the country who are not so fortunate in terms of resources. And we can provide them with everything, including our own, and I'll talk a little bit more now, but we can help them in so many ways. And so this was a study that was funded by National Institute of Health and a GRI, which is a Genomic Research Institute of NIH. So we have created this virtual genome center for infant health, or we call it VIGOR, that supports the genomic sequencing in sick newborns. And it's a proof of concept implementation study in which we will examine a novel care model to deliver genomic medicine to newborns. And we are working to implement VIGOR in 8 NICUs. So now we have already enrolled 8 different sites where we are enrolling their patients. So this is the team, and this is the 3 co-PIs and the team. It's a team sport. It cannot be done by one person. So we are all working together to get this made possible. And then these are the sites from different parts of the US. 3 of them are from Massachusetts, 1 from New Jersey, 2 from Texas, 3 from Texas, and then 1 from Miami, which I recently joined. So what we are trying to do, we are trying to build this program where we can enroll 250 newborns with potentially genetic conditions. And then we help them with sequencing. We also help them with interpretation by giving our own interpretation of the findings, including research opportunities, therapeutic opportunities. And then we also do research reanalysis of the data. If we don't find anything, we can do the reanalysis. I'll talk more about the reanalysis part of exome, because I'm sure a lot of you have sent exome and found that either it came back with a negative result or a VUS. So what to do next? That's what we are working on, is to look at the data ourselves. And I will show it a little bit later how useful it is, because we can diagnose a lot of those patients after we do look at the data ourselves. We're also looking at how the families, like how appropriate this is, how feasible this approach is, how many families agree to enroll with us, if we can take care of equities and satisfaction, and all the other outcomes that often we look at when we are doing a study like this. So what we have done is that we have built this website called virtualgenomecenter.org, where we have created slides, and anyone can go and learn from those slides about genomics. And it's pretty useful. So if you want to, happy to share, and it's open for all. And then we are also, so these are the modules that we've created in those in lectures. And then we are also looking at focus groups. So we have already, in fact, this is a little old slide, but we have enrolled 16 babies now, and we are getting more and more data in terms of what we are surveys from families and physicians, and what type of diagnosis we are making, and what our reanalysis rates are, and all those things are being done. So then moving on, so this is about the NICU. I'm going to move on to the next topic, which is what's the utility of sequencing in healthy newborns? And that's a much more controversial than the sequencing in the NICU population. And that's, so we did a study called BabySeq in 2013 to 18, where we looked at this exact problem. And so this is a statement from Francis Collins, who used to be the NIH director, recently retired, but he said that over the course of the next few decades, the availability of cheap and efficient DNA sequencing will lead to a medical landscape in which each baby's genome is sequenced. And that information is used to shape a lifetime of personalized strategies for disease prevention, detection, and treatment. So is this the crystal ball that we have been waiting for? That's the question. So what we did with this BabySeq study, this is another NIH-funded study that we were part of. We did this enrolling babies and families from well baby nursery and the ICUs and randomized them to genomic sequencing and non-sequencing arm. And we reported all the variants that were pathogenic or likely pathogenic in childhood onset conditions, but we also reported for few highly actionable adult onset conditions like BRCA1 and BRCA2. And then we also reported on carrier status. So for example, if someone is a carrier for cystic fibrosis, that was reported to the family, even though it's not directly relevant to the patient, but it's some information that may be of use to them in the future. And then we also reported indication-based variants for a particular phenotype. For example, if a child is born healthy and then starts to develop seizures, then we have the data and we can look for if there are any seizure genes that the child has a mutation in. And so that was the purpose of this indication-based variants as well. Or if the child is enrolled from the NICU and there has some type of phenotype that we can look into. We also enrolled their physicians and then studied the impact on families and physicians. So we wanted to see what's the impact of sequencing on individual and public health, what is the impact on physician and family behavior, and what is the impact on the healthcare system in terms of economics. So this was a study. We enrolled 325 babies overall, and majority of them were from the well baby nursery. And this was a randomized study. So we did either standard of care or genome sequencing. And then we did the disclosure to the families and the report was sent to the pediatricians, and then it was part of the continued medical review. So this was what we found. Out of the 159 that were sequenced in the sequencing arm, so if you remember, 325 were total number of babies were enrolled. So half of them were not sequenced, half of them, which is about 159, were sequenced. And of them, 18, we could find some variants which were very interesting. One of them out of those 18 was explained the complete phenotype of the patient with a mutation in a gene called ANKRD11, which causes KBG syndrome. There were 3 where it could explain partial phenotype, not the full. And then there were several where we had variants in genes that are known to cause diseases, like there were Titin, 2 cases where we found mutations in Titin, and there was a family history of cardiomyopathy in those families. And similarly, other BRCA2 in 2 cases and other genes. And then there were 6 of those or 7 of those where we did not have a family history, but we don't know what it really means. But these are the findings which are worth following, and we are doing a follow-up study for those families as well. So this was the first randomized study of healthy and ICU newborns to evaluate the utility of genome sequencing during the newborn period. There was a low rate of enrollment in this study, which I didn't talk about, but it was partly because I don't think people are ready, and we gave very little time for families to think about it. But we did find a lot of high rates of likely pathogenic alleles for disease or disease risk. And then there was a high number of carriers. So that's interesting. I didn't show the slide, but about almost 90% of patients were carriers for at least one recessive disorder, which is very interesting. Some of them were like 4, 5, or even one was 7 different recessive conditions. So we all carry some variants in us which are recessive, but because we are carriers, we are not affected by them. And then there were evidence of benefits in anecdotal cases, like there was a child with biotinidase deficiency, which was diagnosed thanks to the sequencing. And then there was some where family decided to do family planning, and it helped them to avoid a child with cystinosis. And then there was one where we the family used this information about BRCA2 to screen members of the family, and that helped them find that who was positive and negative, and it had impact on their family. So there are additional studies are going on, and we need to follow up long term to see how it evolves as a screening tool. But again, jury is still out, and this work is still in progress. In fact, since our study, at least 6 different studies have been started in all different parts of the world, including UK, England study, and then there is 2 or 3 studies in US, and then other parts of the world in Australia and other places. So this is being tested and tried as we speak. This was the team, people who were involved in this study. So it was a big team that participated in this study. Moving on to research opportunities. So this is also research, but I'm talking more about fundamental research where we can really try to figure out genetic basis of various undiagnosed conditions. And so we built this center called Menton Center for Orphan Disease Research in 2008 in Boston, where the goal is to dedicate ourselves to rare disease research. And the part that I was very involved in is the gene discovery core that I was a director for. And we did a lot of work. We did a lot of publications from the Menton Center. We published a lot of papers. We made this biorepository. We were very involved in the community. We also got a lot of funding from various sources and returned the results to families. We found many novel genes. So these are some of the examples of NIH-funded projects that we have been able to do. One is the UDN. I don't know if you've heard of it. This is Undiagnosed Disease Network. So Menton Center was one of the keys for that. And then Baby-Seq that I already talked about, Center for Mendelian Genomics. This is a project that is based at the Broad Institute at Harvard and MIT. And then Vigor project that I already talked about. And then we also had some industry collaborations, including with Alexion, Amgen, and Pfizer. So this is the gene discovery core protocol that I had developed, where we were enrolling patients with undiagnosed conditions, and we get their detailed history, their DNA sample, their cells, and then also do functional studies using cellular and animal models. This family that on the left, this is one of our first enrollees in the protocol who was a newborn, came with seizures unexplained, and we were able to find the cause for that child. And it took us a long time, but those were the days when we just started, and the technology and the analysis was not as advanced. But still, the fact that we could find the cause for the family was a big achievement for them, and they have 4 healthy kids since then. And because this mutation was de novo, the risk of recurrence was pretty low. So this is where we stand. We have 2,500 plus families that are now enrolled within our database. Most of them we have sent exomes or genomes. We're getting sequencing done from different sources. And then we are analyzing ourselves and then using other approaches from Broad Institute or other private vendors like eMedGene or Codified or NextCode. So we are doing all this gene discovery work, reanalysis of negative exome, genetic modifiers, like for cystic fibrosis. We are building codes for genetic analysis and support development of personalized therapies. I'm just going to give you an example, like how we have been using this for neurodevelopmental disorders, which is a large chunk of patients who come to us and who do not have a diagnosis. And these are some of the genes that we have found in last since we started from 2014. And you can see every year we are publishing at least 2 or 3 papers describing some new genes, and some of them are expansion of the phenotype. But this shows the power of this approach. And many of them are still in the pipeline that we are working on, and will be, the first one was just accepted in Nature Communications, and this one was accepted in American Journal of Medical Genetics. So all types of new genes and diagnoses that we are making. And then I told about reanalysis. As I said, 25 to 30% of families receive a genetic diagnosis, but a lot of them still don't have an answer. So that's where we work to enroll them, get their data, and then do our own analysis. And this is because of all these reasons. Their lack of analytical methods. There is still a lot to learn. Only 5,000 of the 20,000 genes that we have are linked to human disease, and many more have yet to be identified. And many times we come across these VUSs, which we don't know what it means. And that's another area of our interest. And then we find candidate novel genes or genes of unknown significance that need further functional analysis. That's the type of work we are doing. So this is just a cartoon to show that we consent the families, get their raw data, phenotype the proband. That data is reanalyzed using our own in-house pipeline, and then any findings is confirmed and returned to the family. This is our approach, just in a nutshell. We are a team of clinicians, biologists, geneticists, genetic counselors, computational biologists, and we use all these different approaches to get to the bottom of this. And this was a recent study we published in the European Journal of Human Genetics, where we did the same approach to 102 infants, and then found that about 18 of them we found a candidate gene, and 6 of them we could find a known gene which was missed. So this shows the power of reanalysis. We have, in fact, subsequently published another paper where we showed that 2 of the cases were missed by the sequencing company, and the second in a recessive disorder, and the second variant was just hiding in plain sight, and we could find it and return the results to the families. So there is a lot of needs for reanalysis in addition to other sequencing technologies, such as whole genome or RNA-seq and others. So these were the 6 cases that we had identified and published in this paper, describing how important this is. And then lastly, we are also very interested in supporting the development of personalized therapies. This is a case that was enrolled in the Manton Center, where Dr. Yu, who is one of the PIs at Children's, he went ahead and found a treatment specific for her, but enrollment to finding the diagnosis to finding therapy was a very unique challenge that was first described, and that was published in New England Journal of Medicine. So this is the type of approach we are now more and more taking, and working in the NICU as well. So as I said, that lastly, I did build this program in the NICU, which is we call it Neonatal Genomics Program. And as a director, I had several faculty, fellows, and genetic counselor, and research assistant who joined me. And we have done a lot of work on rapid sequencing, molecular autopsy, sequencing data reanalysis, and utilize other approaches such as RNA-seq and now more and more long-range sequencing, functional analysis using models, and then integration with the underserved NICUs that I talked about, and NICU biorepository. So overall, I think genomics is in neonatal care. It's a vast area of clinical application and translational research. It can really rapidly diagnose infants affected by genetic disorders, and in addition to diagnosis, it can help lower the time needed, and then impact on clinical care and how it is perceived on clinicians and parents. And so we integrated it in our own NICU at Boston, and since then it is used most often as a first-tier sequencing test. It can be beneficial in molecular autopsy. We need to increase access to rapid genome sequencing in non-NICU. And then research opportunities are huge, and I just cannot tell you how excited I am to be a part of this research and making a difference to one family at a time. It's just a great privilege and honor to be able to work with, to do this type of research. That I want to acknowledge my team shown here, who do all the work. And then these are my funding sources. And this is the Manton Center Gene Discovery Core, and then these are members of my laboratory. With that, I'll end here and happy to take any questions.
Thank you, Dr. Pankaj Agarwal. Over to the moderator, Dr. Archana, to take over the question and answer session.
Hello. Yes. Good evening again, Dr. Pankaj. It was a fantastic talk with a lot of potential for the future. Dr. Abhirama, would you like to continue your comments on the talk, and then we'll ask the questions?
Yes, ma'am. Thank you, Professor Pankaj. It was a very interesting presentation, especially the gene discovery project. I have like 2 doubts. I mean, not doubts actually, 2 questions for you. Probably I'm asking on behalf of all the participants. So if we have a patient for whom we get the report like variant of unknown significance in clinical exome sequencing, is there a way that we can send the report to you and like the data to you, and you can reanalyze and give us the final report?
Yeah, so this is where I think there is a little bit of confusion about what the labs write and what the clinicians write or clinicians think. What happens is that lab is going to go by the strict ACMG guidelines to say that it's a variant of unknown significance. But as a clinician, we can decide if this is truly explains the phenotype or not. So we don't need to rely on the lab to say that this is the right answer. But you are going to be caught up in many situations where you're not sure either. And or a lot of times, or majority of times, in few cases, like you will say, oh yeah, this totally fits with the phenotype, even though it's a VUS, it has never been seen before, and it has all the qualities of it being really causing the disease. That also we can help, but I'm just saying that you don't have to go by what the lab says. You can decide as a clinician what you think is the right answer. But if you don't have tools to help you, then we can help, and we can also, the other ways to have involve more geneticists in India to help for reinterpretation of the report, and don't fully rely on the lab to ask them to change the report. I have heard this question many times where people say, oh, the lab gave it as a VUS, but we don't agree. We think it's explaining the disease. What do we do next? I think as a clinician, you can say, even though the report is saying it's a VUS, we still feel that it may explain the phenotype. But still, and there will still be majority of times when you won't know the right answer, and then that's where we can help.
Okay. And my second question is, are there any opportunity for us to collaborate with you for research or for any funding opportunities available?
Yeah, definitely. We have opportunities for research, and if we can talk about this, like we can come up with some system where people from India who's very interested in this can come and visit the lab and see what we do, or join us and see the type of work we are doing. So, and then take it back to India and work there, or like there are many opportunities. I think we'll have to explore them, and I'm happy to help with that as well.
Yeah, thank you. I still remember like 10 years before, when I was 10 or 12 years before, when I was a postgraduate, the only diagnosis we write for these babies is multiple congenital anomalies or suspected genetic syndrome. So we did not even used to attempt to find out what is happening to the baby, and no genetic analysis used to be done. And then we moved on a little bit. Around 5 years before, we used to put all the phenotypes together, and we used to use the Phenomizer app and try to figure out some syndrome. And even then, most of the time, we'll end up doing only the karyotype, and we did not used to proceed further. But nowadays, like we have an array of tests starting from karyotyping to microarray and exome sequencing, and even whole exome sequencing and whole genome sequencing. And we end up doing sometimes reverse phenotyping as well. So because it is very easy to send the blood test, and once the genetic result comes, we try to figure out whether it is fitting with our clinical phenotype. So we have moved quite a lot in this. And in our NICU itself, we diagnose around 2 or 3 genetic conditions every month or so. So the use of genomics in NICU has really expanded a lot. And thanks to your talk, it was very nice and very interesting. Over to you, Dr. Archana, for taking up the questions from the audience.
Yes, thank you. So Dr. Pankaj, we'll start with the questions. I think this one you already answered, Dr. Ashok Kumar. Many times one gets the ES report as VUS. How do you interpret it? I think you answered the question, right? You don't, any other comments do you have?
So in fact, I'm writing a paper on VUS, the elephant in the room, as the title, because I think it's a huge problem for a lot of clinicians, because they don't really know how to handle it and how to interpret the findings. And every VUS is created different. So there is a whole shades of VUS. Some are more likely to mean nothing, and then many of them may really mean a lot to the patient phenotype. So I think what we have done is to club them all together under the umbrella of VUS, but it's really the case by case and VUS by VUS, we have to tease it out. And that's a challenge, and that needs efforts and resources and desire to solve these cases. So I think we don't need to give up on those. As I showed in my example of patient who died, we had the same problem. We had a variant which was clearly pathogenic, but the other variant was VUS. And the metabolic team was not convinced that this is the right answer because one of the variant was VUS and patient was not behaving. But at that time, because we had cells to prove it, we could confirm it. But many times, that's why I think doing downstream testing and more in silico analysis using different approaches, and that's something they can learn from us as well. And there's also a lot of data available, like how to approach this type of problem. So there is definitely a need. And as we do more and more of these testing, the number of USs or GUS, as we call it, gene of unknown significance, and variant of unknown significance will keep going up. So just to give you an example, one of the paper we published in European Journal of Human Genetics, where we found about 18 patients had like some type of candidate gene, which we didn't understand. And in total, and then there were 15 from another group, which was from the lab itself. 15 of them were classified as unknown significance. And about half of them are now new genes that have been diagnosed. So a lot of these VUS or GUS may turn out to be a real disease causing. I'm not saying 100%, but a lot of them. So that's something we need to be mindful of.
So one day this VUS reports, you will actually be putting a name to it.
Yeah,
like more and more.
I think, yeah, this is where I think we need to start taking some responsibility away from the labs and do it ourselves. To say that even though the lab saying VUS, we think it is likely benign, and that's what we are doing in the Vigor project that I was telling you. We are giving our own thoughts on it. Like, do we still want to classify as VUS, or we think it is more likely to explain the disease? And that's an additional benefit of having a team of people who are looking at the variant and making sure that we have looked at from every angle and every side of it, and then come up with an interpretation where we all agree that this can explain the phenotype. So that's the way to do it, because VUS are gonna be part of our lives as this technology grows. And there may be even one VUS, there may be 5 VUSs. So which one is the VUS which explains the phenotype? Or maybe none of them explain the phenotype, or 2 of them explain the phenotype. These are the questions that we need to address ourselves. So the labs are not gonna be able to do it. We have to do it as clinicians.
I think I'll follow it up with another question, which is somehow connected to this, is from Dr. Hassan Maldar. Do you follow up the babies that have positive results?
Yeah, we do. Yes, yeah, we do follow up. We used to have a special follow-up program for these type of patients which were diagnosed and were followed on a regular basis to see what's going on and how their disease is evolving. Yes.
And what did you find, if I may ask?
Healthy
babies that got screened and had positive results.
Yeah. So that's where I think, for example, I told you about ANKID11 case, right? That was a case when we diagnosed them, that child did not have any of the features of KBG syndrome. He just had some anal stenosis and some very mild dysmorphism, which would have been passed as a normal child. But then after 6 months or 12 months, we started to see the teeth, they were abnormal, and things started to show up that were consistent with KBG syndrome. So there are gonna be phenotypes that will evolve, because newborn time is not the time when a lot of the phenotypic findings are gonna be identified. So as you follow them, you will start to see that there are real changes that are happening which are consistent with the disease. So genotype first is probably an approach that is eventually going to become more and more popular, because it may help us find conditions sooner rather than later. Like same thing with Duchenne muscular dystrophy. There is a program now in Massachusetts where they are doing newborn screening for Duchenne muscular dystrophy at the newborn age in male child. And as you know, most of the patients will not present till 5 years of age. And so there is a window of time when this can be picked up, and maybe potential therapies can be tried sooner rather than later, rather than finding these conditions much later. So I think newborn screening is another area that is evolving as well, based on the studies that we have done in baby-seq, and whether we should do the entire exome or genome, or we should only look at like 200 or 300 conditions that are related to it, and that may benefit from this approach. Those are the questions that will be answered in next few years. So
definitely sounds very exciting.
It's very exciting time, absolutely. As I said,
it's the future, I think.
Yeah, it's a future, and we are also doing a lot of multi-omics now, for many research projects where we are using RNA-seq and proteomics and other things to really understand diseases at the molecular level. And it has really giving us a lot. This is more in the research realm rather than clinical realm. But this is going to be the future as well. And more of these things will be translated into clinical care. So it is exciting times.
Right. So next question is from Livert Flores. The question is, there is a genetic factor in almost all pathologies like NEC, hypoglycemia, and HIE. So she wants to know if there is any prenatal predictive marker to request from the mother.
Yeah, that's a very, very interesting question. And this is an area which is relatively poorly developed. And this is one of the areas that I'm very interested in to see as a neonatologist, how we can really come up with a score or polygenic score or some type of score we can give to predict that this child has a higher risk of developing NEC compared to others, or a high risk of developing severe BPD. And these are more polygenic conditions. This is not a Mendelian conditions. So there are many different genes that are working together, or at least few genes that are working together. So we need to understand them. We definitely know that many of these conditions, there is a strong heritability factor. If you see, there are studies which have been done in identical twins versus dizygotic twins, and there is a clear difference in the risk of BPD or NEC or even ROP. All these conditions have a heritability as a big factor. So we haven't really teased them out yet, and that's an area that is of huge interest for me and my team that we are working on.
Okay. Dr. Abhirama, would like to take the next question?
Yes, ma'am. So Dr. Ashok Kumar is asking, many times one gets, okay, so that is over.
No, that has been, the first two have been covered. The next, Dr. Thomas Jones. Okay.
Yeah. Dr. Hassan Walter is asking, what is the difference between whole genome sequencing and whole exome sequencing? And even I have a question to add on to this. So what is your experience between clinical exome sequencing and whole exome sequencing? I mean, like, what is the additional yield of doing a whole exome rather than a clinical exome?
So clinical exome and whole exome is the same thing. There is no difference. Whole exome, its basic goal is to cover every gene that is 1 to 2% of our genome. That's the exome. They also cover a little bit of intronic regions next to the gene, but it's very haphazard. It's not clear. It's not clear cut for exome. But 80 to 85% of monogenic conditions have variants in the coding region of the gene, which means exome should cover a lot of them. And there have been many studies that have been performed where genome versus exome. First of all, genome is 100% of your genome. Exome is only 1 to 2% of genes that are coding, that create proteins. That are the ones which is the focus on. So in terms of size, it's a very different, it's only 1 to 2% of genome that is exome. But in terms of for monogenic conditions, people have studied them and looked at how incremental benefit of genome versus exome. It is about 5% in several studies, 5 to 10% at the most. So if your facility does not have genome, go for exome. But if your facility has genome, then go for genome. But if you don't have genomes or the cost is a big differential, then go for exome. So if the genome is a lot more expensive than exome, because exome, other advantage of genome is that it has a very uniform coverage compared to exome. Exome is very difficult because the way it is done, there's amplification of the regions, and that can be haphazard, which means that exome, especially in 5' UTR regions and exon 1, they are poorly covered by exome. So if you have a variant in exon 1, which is very GC rich, as we call it, is very difficult to, often in many genes, it is an area that can be missed. Or then there are a lot of repeat regions in many genes that can be also missed by exome. So genome is a better test, and it can also predict more like smaller structural changes that can be missed by exome. So there are many advantages of genome over exome, but in practical terms, if you have exome and it's affordable, go for exome. Don't wait for genome because often genomes are more expensive. The other thing I want to emphasize is that send trio exome. Don't send only proband exome, because if possible, if it is a cost factor, then again, just send the proband. but you will end up in a lot more VUSs if you have only probe and exome compared to if you add the parents as well. And here, at least in US, they don't charge anything extra for parent exome because they have to do less downstream work. So once you have data on both parents, then it's easier to interpret what it means. Because if you don't have both parents' data, you have to phase the variant in recessive conditions. You don't know if it is de novo or not. All these things play a role in your diagnostic yield. So in some ways, it's very important to do trio more than exome versus genome. And if you can do genome, even better. I hope that answers the question.
Yeah, but unfortunately in India, we have to pay triple if we have to do a trio sequencing.
Yeah, that's a problem because companies need to start thinking of something that we should reach out to them and say that that's a little unfair. Because
would you say if the exome sequencing comes normal, negative rather, then we should go ahead with the genome sequencing when you're sure that there's something genetically wrong with the baby?
So there are two approaches. One is that you can get the data and look at ourselves to see if there is something missing, because there's a good chance that it may be a VUS that if it's completely negative and you strongly feel that there is something going on, definitely genome can be tried. But if you have VUS or you have new gene that you don't even know what it means, then it's worth exploring that first before jumping on genome. I don't know if it makes sense. But there are different types of reports you will get. Sometimes you'll see completely negative, they didn't find anything. And you are 100% sure that there's something going on, then you can think of genome. But if you found a couple of VUSs and you don't know what they mean, then first get those sorted out before jumping on genome.
That makes sense, yes. So we'll go to the next question, Dr. Thomas John. He says communication with parents regarding genetic testing often is by non-geneticists, like usually a neonatal team member. What would be your advice regarding points to discuss with families as part of the consent procedure for genetic testing?
Yeah, this is a great question. And this is something that as part of the Vigor project that I talked about, we are trying to encourage the neonatologists to take the leadership on the cases rather than, because as you know, there is a shortage of genetics everywhere, right? Even in US, there is a whole huge shortage of genetic consultants and counselors. Many NICUs don't have anyone. And here, I think we can take the lead as neonatologists and say that we can learn. It's not that hard. People are learning echocardiogram. People are learning ultrasounds as neonatologists, which is essentially a job of a radiologist. We can definitely learn genetics. We can learn how to approach the families. What are the main issues to look into? Make sure that when a test comes back negative, for example, don't say that the child does not have a genetic condition. That's the biggest mistake people make, because these technologies are not perfect and we still don't understand a lot of these conditions at the molecular level. We can only say that the test came back negative. We still don't know what it means, but we need more workup, or we need to keep working rather than saying there's no genetic condition. That's a common mistake that people do. So really understanding what you are getting into with these tests and explaining the parents upfront what they are getting into is very important.
I think the challenge will come when one day in the future it will be a screening test.
Yeah.
And that's really.
There will be a different level of challenge. Yes. Yeah.
Yes.
And
you probably face this challenge
recommend
when you were enrolling. Sorry.
Yeah. If it is a challenge, it's good for us because we can keep working. So if the challenge is solved, then it is. No, I'm just joking. But what I'm trying to say is that there are a lot of challenges like this that are gonna keep coming. And I don't even know at this time whether it's the right thing to do by doing in a healthy newborn, because we still don't understand a lot of these variants, how to interpret them, how it adds to the cost to the family and anxieties and parental relationships. And all these things are important before we jump on offering this type of test for healthy newborns. I think for NICU patients who are sick or who have a likely genetic condition, I don't think there is any doubt that this is the best test. Just do genome or exome as the first line. But if you are not, if that's not the case, you want to do every baby in the NICU or every baby healthy baby, that's a different challenge. And interpretation is a big part of it. We are not even able to interpret the NICU's critically sick babies variants. Think of this multiplying by so many fold in healthy newborns.
Right.
It's a real challenge.
Yeah. Please, Professor Pankaj, please correct me if I'm wrong. So you said like clinical exome and the whole exome sequencing are the same. But what was my understanding is there are around 30,000 genes discovered, but only 5,000 to 6,000 genes are implicated in any genetic disease.
So they when they report, so this is where like they use the same platform to do sequencing, which is the technique is the same. So the reporting may be only on those 5,000 or 6,000 genes that are known, and they can include only those conditions in the report, or they can include all the 20,000 genes that are known and put information there. So it's up to the lab, but it's a decision they make. And in here they don't differentiate between genes which are known or unknown. They put whatever they think is strongly interesting, they will put it. But a lot of time they won't put every gene because they don't know what it means.
Okay.
So that's the only difference. It's clinical interpretation. The platform is the same.
Okay, I understood. Dr. Ashok Kumar is asking, the many sick babies in NICU receive blood transfusion. So what is the optimal time interval between blood transfusion and exome sequencing?
Yeah, I would say usually because we give them leukocyte poor blood transfusions in most times, I would say at least 3 days as a way to avoid that situation, preferably 7 days, but 3 days is, I think, okay to go for. But I would definitely wait for 3 days for a transfusion.
3 days.
Mm-hmm.
Okay, Dr. Praveen Rao says he wants to know the role and utility of mitochondrial gene sequencing.
Yeah, that's a great question again. So, mitochondrial genome is 99% nuclear and 1% is mitochondria. So most of the nuclear genes, most of the genes that form the mitochondria are nuclear, 99% of them. Only 1% are in the mitochondrial genome. So if you have if a patient has cardiomyopathy, hypertonia, seizures, it fits into a mitochondrial condition. Still, if you do genome or exome and it comes back, genome can also cover for mitochondrial genome. Exome does not, because there's so much of mitochondrial DNA, they throw it out and they just focus on the exome, which is nuclear DNA. So for mitochondrial, if you are concerned about a mitochondrial condition, you can think of either sending a mitochondrial genome sequencing or send an exome. If it comes back negative, you can send a mitochondrial genome, or you can send a genome alone, because that should, again, every lab has their own pipelines and some labs are not so good. So these are the things that, again, one thing I want to tell everyone is that the genome, even though we call it whole genome, the technology is still not the best. And so what they do is they have like 250 to 300 base pairs of sequencing data that they tile along using a normal genome as the reference. But if you have long read genome, which means you can sequence 200,000 to 300,000 base pairs at the same time, that's a lot better than doing the current whole genome, which does not use that technology. But that technology is coming, and very soon that will be used more often than the current whole genome. So just a caveat, all these technologies have their own drawbacks, and they are getting better, but still a long way to go.
Thank you. Dr. Chandramouli is asking how to contact you, Dr. Pankaj Agarwal. There is a patient.
Yeah, I will put I will share my information here. So you can email me anytime. And I also have my Harvard email as well. So any email is fine. I'll put both just in case. And then, so just reach out to me anytime. And I have a whole team of people who are working on this problem. So we can definitely help. Okay.
There's another question from Dr. Hassan Maldar, whether we have to send parents whole genome sequencing as well.
Yeah, as I said, that I would, if I'm given a choice between trio exome sequencing versus only probe and whole genome sequencing, I will take trio whole exome.
So trio means the baby and the parents, right?
Both parents, yes. Okay. Yes. But if you have, the best choice will be have trio whole genome sequencing. That's number one. Next is trio whole exome sequencing. And then you can have whole genome and then whole exome for the probe and only. So that will be the order that I will, based on the affordability, And based on I think the best option is to do trio whole genome. But if parents cannot afford, then do trio whole exome. And if they cannot afford that, then just proband genome, or then lastly proband exome. That's what I would also say that there are a few conditions, especially if a patient is born with hypotonia. Just be careful with exome only approach, because there are conditions like SMA, and then there is a Prader-Willi, and some of these may be missed by the exome. So just extra careful for some of the repeat disorders like myotonic dystrophy. This is another example where this repeat cannot be picked up by exome. It needs genome or specific test. So there are a few conditions that cannot be picked up, but in the big picture of things, you should, first line of testing should be exome or genome, unless you clear-cut suspect that this child has SMA based on family history or based on anything else, or think of Prader-Willi, child looks like there is a Prader-Willi, then you can think of sending those tests first. But most of the time, I would say exome or genome is probably the preferred test for any NICU baby.
Yeah, thank you. Again, there are questions on the choice of genetic tests. There are a lot of young neonatologists here, I can see. So for the benefit of all of us, what we do as of now is, if we can fit in the phenotype of the baby with some chromosomal disorder, we send a karyotype. If we can fit in a microdeletion syndrome, we send a microarray. Otherwise, we end up sending exome sequencing for all the babies. So could you please enlighten us on how do we choose between an exome sequencing and a microarray?
Yeah, that's a good question. And I would say that a lot of times, because the exome technology has improved, a lot of the deletions can be picked up by exome. That's my experience. That because microarray also only picks up if your deletion is 50,000 base pairs or more. So it doesn't pick up on very small deletions. And that's where genome is better than exome, but exome is pretty reasonable. So unless, as you said, if you said like you have a child who has, let's say, thymic aplasia and child has hypocalcemia, you don't need to do exome or genome. You straight send microdeletion with microarray at 22q11. But or if the child has showing clear-cut signs of trisomy 18 or 13 or 21, don't need to do microarray. So I think this is where clinical judgment can help. But those cases will be few and far, and they will be picked up by exome or genome as well. So it is, if you are strongly feel that this is a condition that can be picked up on microarray, then definitely send it. And but if you're not sure what you're dealing with, then exome or genome makes the most sense.
I remember a case I had once where the exome sequencing did not pick up anything, but then the geneticist saw something and did a karyotype, and it turned out to be trisomy 9.
Yeah. Again, this is where the lab's expertise also comes into play. And if it is a full length trisomy 9, then it can be missed by exome because they won't see any change. They will just have a higher reads in this exome in the chromosome 9. But it's hard to use that information and say, oh, there is something unusual about chromosome 9, that everything is, instead of 2x, you are seeing 3x. So this is where the expertise of the lab is important. But as I said, that if you are you can either do send both microarray and exome at the same time, especially for multiple anomalies, or you can start with microarray first, and then if it's negative, then send exome, or you can do exome first. And because a lot of the multiple anomalies also are single gene defects. So as you know, CHT7 is a common example of multiple anomalies, and it is a single gene defect. So microarray is not great. Exome has improved, but still can miss some of this, and genome should be able to pick up.
So are you saying that exome sequencing can totally miss trisomy 21, 13, and 18?
There can be a chance, because they are really not seeing any difference in when they are looking at the coverage. They may not notice that this particular chromosome coverage is a lot higher than other chromosomes coverage. So they get so unless they're looking for it, they may miss it. That's the thing. So that's where lab's expertise is critical. to make sure that they know, or you can say that I'm also suspecting some type of chromosomal defect beforehand, and then maybe they can focus on that, and they can give some idea. But if you have like how they pick up on like exome, how they pick up on copy number is by looking at the coverage across that entire chromosome, and then they notice some dips in coverage or increase in coverage, and that's how they can say that there is some either duplication or deletion, and that tells them that this is what's going on. So it's possible it should be possible, but as I said, labs are also all not created equal. I have seen some labs are terrible, and some labs are great. So it's very important to go to a good lab which has a good reputation for quality work. So
how long does it take to do the sequencing?
it can take, depending on,
Hours.
like we are nowadays 5 days, you can get an answer. But if you're doing a research setting, you can get in 16 hours. Even there are claims about 8 hours for an answer, but that's much more in the research realm where there's like, it's not being applied clinically at this time, or very few places are even thinking of it, because it really doesn't make that big a deal except in a very tiny fraction of cases that you're missing 1 day is going to completely change the treatment. So you have to see the benefits and see the costs involved, and that's why if there is a strong suspicion for like riboflavin deficiency or something of that nature, which is a genetic condition, and it can be treated with giving some extra riboflavin, then yes, that's critical to find it sooner. But for most of the time, 99.9% of the time, it's not that critical. So it has a role, but I don't think it's practical yet. It's more in the research realm, because you need a lot of resources to get there.
So the decrease in the time taken, is it because of the fact that it is becoming more and more automated nowadays?
I think the decrease of the time is basically you are putting the entire team on alert. The moment the sample comes in, let's say middle of the night, someone is there to start processing the sample right away. And it's like automated pipeline that goes from data to analysis to AI and making sure that everything is covered and they have a good pipeline. So that is a level of commitment that is very expensive. And so cost comes into play a lot. So I think we would love to get an answer within an hour, but the reality is that it's a complex test, and it has lots of steps that can be really narrowed down if there is fully dedicated team and resources available. But for most times, it's not the case.
Okay, Dr. Usha Devi has a very interesting question. During pre-conception counseling, when the proband sequencing or genetic tests are not done, can we opt for carrier whole exome sequencing in one of the parent, and after that result, do Sanger sequencing for that specific variant in the other parent due to cost issues? Will we miss anything by this method?
Yeah, this is a good question. I think the first thing to remember is Sanger sequencing takes time. It does not happen so fast, and you have to cover the entire gene, and you may still miss something which is intronic, which may be playing a role. So it's not ideal to do Sanger. I think the time it takes for developing the primers, doing like extracting DNAs and getting the primers, and then doing the PCR, sending for analysis. Running through the chromatogram and all that takes time. And a lot of time primers fail as well. So it's not a perfect test. I've seen it so many times. I used to do Sanger all the time, PCR followed by Sanger sequencing. And it can be frustrating test. Many genes are poorly covered by Sanger, especially in the 5' UTR and the exon 1, because they are very GC rich. So you need very specific kits to amplify that region and sequence them. So it is a nightmare. I would not recommend it at this time.
Professor Pankaj, I think she means that like gene sequencing by any method, probably next gen sequencing also. So what she's asking is, can we do carrier screening for the mother, for example, and then once we get a mutation in the mother, can we screen for the same mutation in the father? That's what she
It may not be the same mutation. It can be a different mutation. Most of the conditions are compound heterozygous. So
Yeah,
you can do
the
it.
same gene, that gene will be sequenced to find out any mutation in that gene.
So that's what I mean. Like some genes are really big. Like there is a gene called Titin that has 300 plus exon. You're not going to sequence each exon one by one for Sanger. So Sanger is not a practical approach. You can think of there's also these gene panels. You can think of potentially where this, but again, the cost will be same. You are not going to save any money. A lot of the panels nowadays are done on exome. They are using exome platform to do the panels as well. So it's does not add much value. I think it's better to also screen the father if there is something found in the mother, so that because that can be a compound het mutation which may be hiding in some other part of the gene. So only if you have a consanguinity and there is the family has like when there's consanguinity and you find a variant, yes, then you can look at that variant in the father as well and make sure that is not. But that's very few % of patients. Overall, it's not. Most of the time, the recessive disorders are not homozygous; they are compound heterozygous.
Dr. Praveen Rao was asking, please comment a word on utility of next generation sequencing.
Sorry, what's the question?
Utility of next generation sequencing.
Utility. So these are all next generation sequencing, all these multi-gene panels, exome, genome, they are next gen sequencing because they use a very different approach than the sequencing we are used to. So that's what I was talking about, unless Stacey wants something else.
I have a question. This Phenomizer app used to be a little comprehensive before. Now it has become very complicated. Even if we put some 5, 6 hard handles, it gives us at least some 100+ syndromes from which we have to filter and find out what we are looking at. Is there any other platform for us to use?
So have you tried Face2Gene? Have people use that Face2Gene? Like if you have a facial dysmorphism, then you can put that data into Face2Gene and they can give you 5 different conditions that they think that matches. They have a huge database of AI-based database where they can, that's a company, so it's a cost. I don't know, I would not go for it, but if someone wants to try that, that's a potential. But in terms of Phenomizer, they're all like, I feel like so much we have learned over the years that this sequencing and finding these genes, there is so much of phenotypic variability. It's very hard to really pin down a condition just based on phenotype. I think phenotype is critical for when you find, I think a combination of phenotype and genotype is the key.
Okay.
Right. We don't have any other questions. Does anyone in the audience have any questions that they want to say it loud?
I have a question on this VUS. You told about in silico prediction tools, right? But when we discuss with the labs here, they say that even if the in silico tells that the mutation is probably pathogenic, they will not be changing the report from VUS to likely pathogenic. Is it so? Because the likely that classification is only based on literature. It cannot be changed based on the in silico tools.
So that's where in silico is more helpful for us as a clinician, not for them. They are going to go strictly by their guidelines. But for us, because they are trying to save their back, because they don't want to, but as a clinician, you don't have to, like, it's similar to MRI. When you read MRI, you say, oh, I see something. I suspect that this may be playing a role we need to follow or something. It's a similar thing. Like as a clinician, you can say that I found this VUS. It's a variant that we think it's interesting. We need to do some more work and we can get to the bottom, but it's still, we think that this may explain the condition or it may not explain the condition based on what you think. So I think we have to use our own judgment to decide how to explain those results to the families. But I think that's where having a deep knowledge of how to interpret those VUSs is very important. And that's what we do as a team, to go over the VUS, look at ourselves, put our own resources into it and see what we think. And then have a couple of people sort of agree to it. Because if there is a disagreement, we won't do it. But if everyone agrees that, yeah, this explains it well, and This is what the literature says. This is where the mouse, like we often use a mouse model, for example, to get that information as well. Like if mouse model has shown that, let's say there's a VUS in a new gene, which a patient has a cardiomyopathy, and I go into the literature and found that the mouse model with the same gene has shown cardiomyopathy, I would be more inclined to think of that this may be playing a role rather than not playing a role. So this is just an example of how you can use different resources, not just human-based resources, but outside human as well to look into.
Okay. Thank you.
So I wish there was a simple answer, but there is no simple answer here. We just have to play our part.
We have one last question from Dr. Usha Devi. Can we upgrade VUS to likely pathogenic? Or
They will. Once they do find a paper that is published or literature updates, so it does happen. Some companies will ask you, you can ask them to yearly do a reevaluation or reclassification, and sometimes you can reach out to them directly and say that this is the variant you found, and I found this paper published. Can you revise again? So you can also do it proactively by following the literature and see if something comes up. Or some of the companies will reanalyze all their patients' data that has been reported, and then go back and see periodically and see if there's any change in there, and they can change, upgrade it or downgrade it based on the finding. But this is not done routinely. This is not done routinely. This has to be something that can be pushed to these labs, or there are ways to find it out.
what about the role of segregation analysis for this reclassification? Does it help?
I don't know exactly what, as I said, I'm more in the discovery side of things. So segregation is like, that's where trio will help. If you have if the variant is over two variants, one is from father, one from mom, that helps, rather than you do only probe, and then you don't know if they are both on the same allele or they are on different alleles. That's very important as well. So I think that helps. So if you find like two, like I will give you an example, if you have myopathy and you have two RYR1 mutations and both are likely pathogenic, you don't know whether both came from one parent or both are segregating from one parent, one from father and one from mom. So that's also important to find out. So especially if the mother does not have the disease, then there is a good chance that one is coming from each parent, but you cannot be sure unless you do the segregation analysis.
So you mean to say that trio will help us to reclassify VUS to pathogenic?
Yeah.
Thank you.
Hope there are no more questions, right?
Yeah.
No, there are none. It was simply fascinating to hear your work and how your empire is growing. We really definitely wish you the best of luck, and we're waiting to see what comes up later in the future, what recommendations come up.
Yeah, no, definitely. This is very exciting. And as I said, that I'm more than willing to have someone come here or over the year. If someone wants to learn themselves, it's not rocket science. It's just needs resources and team and people who are interested in this. So if I can do it, anyone can do it. There's no rocket science.
Sounded like rocket science to me.
Because it is built over the years. So that's why it does look a little complicated, but it is fascinating. That's all I can say. It's a fascinating field.
Thank you, Dr. Pankaj.
Thank you very
So much, Dr. Pankaj.
Okay.
Since the question answer session has come to an end, and on behalf of Dr. Manoj, the chair, NNF India and NNF Kerala, let me express the vote of thanks. First of all, I would like to thank Professor Pankaj Agarwal for his excellent session on role of genomics in neonatal care. You have thrown much light into an area which is a little darker for many of us. Good luck, sir, to all the great research projects you are involved in, the genetic issues and care of newborn. Thank you so much, sir. I would like to thank both our moderators, Dr. Archana Bilagi and Dr. Abhirama Lida, for moderating this session and making it very lively. Last but not the least, I would like to thank all the delegates who have joined on this day, 11th of May, from all over the world to hear this talk. let me remind our viewers that for those who have missed this live session, there is a recorded YouTube version which is also available online. Before I conclude, let me remind you all about the next session that is on 1st June, Thursday, 7:30 Indian Standard Time. The topic is what is new in iron supplementation in newborn. The speaker is Dr. Raghavendra Rao from USA. Once again, thank you all for attending this session. Hope I can conclude this session.
Thank you, everyone. Thank you so much.
Thank you, everyone. Thank you, Dr. Matthew.
Okay.
Thank you.